Hi learners, it's Molly from Sound Nerds, and this is going to be an introduction video to contrast-enhanced ultrasound uses in abdominal sonography, and this really is intended for the general sonographer and general sonography students. Okay, so why are we talking about contrast in ultrasound? Well, here's what's in it for you. By the end of this introduction, I'm hoping that you'll understand what contrast-enhanced ultrasound is, how it works, and where it fits in your role as a sonographer. So the goal today is kind of to learn a little bit about the basics, talk about a little vocabulary like what microbubbles are, and then a little bit about the different imaging phases, what they mean, and kind of what to look for. So we're going to get through some real cases at the end here so you can kind of start recognizing some of those patterns and really just kind of see how ultrasound can be an effective tool in diagnostic imaging with the liver, kidneys, trauma, transplant, pediatrics, with more and more uses being explored every day. Contrast-enhanced ultrasound, or CEUS, allows us to see dynamic vascular patterns that grayscale imaging just can't reveal. So instead of injecting iodine-based contrast or gadolinium-based contrast, we use microbubbles that are going to stay within the vascular space. So this really makes it possible for us to assess how blood flows through organs and lesions right at the bedside. So contrast-enhanced ultrasound gives us a nice, clear view of the pathology, especially in the liver and kidneys, without needing radiation or nephrotoxic agents. Now, as sonographers, we are usually there to assist with the contrast-enhanced ultrasound at this point in time, needing a radiologist usually present to administer the contrast agent and to watch and read the screen as the contrast is utilized. But I wouldn't be surprised if it already isn't happening or is going to start happening more and more, that as radiologists become more comfortable with them, it really could be kind of a solo exam like it is for our cardiac echosonographer counterparts. Now, the magic of contrast-enhanced ultrasound lies within the microbubble itself. These are tiny gas-filled spheres, usually stabilized by a lipid or protein shell. Once they're injected, they're going to travel with the blood and then reflect ultrasound differently than the tissue. What's important to remember, though, is that they don't leave the vasculature. They are going to highlight the vessel and the perfusion that's occurring, not the tissue. So most agents do last long enough for us to get quite a bit of information out of them, can even last up to 6 or 8 hours after they're prepped. And this again is really going to allow for a detailed assessment across multiple passes or delayed phases. So here we have an example of a little bubble here. We've got the phospholipid molecule, so that's going to create the shell of the bubble. And that shell needs to be small, it needs to be stable, it needs to be flexible. And then inside of it, it's going to have a gas, and that is the part that is going to expand and contract as it reacts to the ultrasound wave. So this is a little bit of a throwback to physics, and we'll touch back on it a few more times throughout this lecture. But remember, during the compression part of a sound wave, the pressure is really high, the density is really high. So when the compression part goes through this bubble, it's going to squeeze this bubble and contract it down. But then as the trough, or the rarefaction part of the wave goes through, it's going to allow this bubble to expand. And again, we'll talk about it a little bit later, but it's with the contraction and expansion of this bubble that reflects the sound differently and allows for that strong signal to be seen on our screen. There are 4 main agents used worldwide: Definity, Lumison, Optison, and Sonozoid. Each of these is going to have its own preparation process and kind of what gas is inside of them, what the shell is made out of, but they all really do rely on the same principle, that a microbubble is put into the bloodstream and then we observe how it interacts with the ultrasound waves. So one agent may be preferred over others based on just regional availability, or it might even be the organ that's being studied. For example, Sonozoid has a special liver-specific phase, which we'll discuss a little bit later, but regardless of which agent is used, safety and effectiveness remain high across the board. So unlike CT or MRI, which can leak into the tissues, microbubbles again stay strictly in the intravascular space. And this is actually a really big strength of the ultrasound contrast agent, or UCA. It's going to allow us to study the vascular architecture and perfusion without paying attention to all that background noise from the tissue enhancement. And even more so, there is no renal excretion involved, making contrast-enhanced ultrasounds a really safe choice for patients with kidney dysfunction. And then even some of our newer microbubble agents that are being designed are going to bind to specific targets like tumor markers or endothelial receptors, which then opens the door to molecular imaging. So in this example here, this is an MRI, and we can see this is the before gadolinium injection, and it's the same idea as MRI and CT contrast. We inject it into the blood, and then it's supposed to show up as brighter or enhanced on whatever modality it is using. The big difference, though, is that gadolinium, CT contrast, those are supposed to also leak into the tissue itself. So in this example, it really highlights the whole tumor. But with ultrasound contrast, it's a little bit different. We are only looking at the perfusion of the lesions. So we would see how this tumor fills with blood and then how the venous portion kind of pulls the blood out of it as it's replaced with blood that doesn't have the microbubbles within it. But again, the really big part of this too is that gadolinium and the iodine-based CT contrast agents actually do carry along some risks for the patient, especially nephrotoxicity. And the UCAs don't carry along that risk. So if we have a patient that cannot have contrast under MRI or CT, ultrasound contrast is a really great option for them. To interpret a contrast-enhanced ultrasound, timing ends up being everything. So once we inject the microbubbles, we need to monitor how quickly and for how long a structure enhances. So we typically divide the observation into 3 phases. First, we have the arterial phase, which is the first 10 to 30 seconds after injection. And then we have the portal venous phase, which is the next 30 seconds to about 120 or 2 minutes. And then we have the late phase, which is 2 minutes to 5 minutes or more. Each of these is going to provide a different diagnostic clue. For example, tumors with abnormal vasculature may show early uptake and then rapidly wash out, while benign lesions tend to enhance gradually and then kind of stay enhanced throughout the late phase. So here's a nice little graphic that kind of shows some of the different patterns that we see, especially in liver lesions with contrast-enhanced ultrasound. So hemangioma, focal nodular hyperplasia, and adenoma, all benign, are slowly going to bring that contrast in. And then in the little bit later part of the arterial phase, they'll be completely or mostly completely filled in, and then it stays. And that's a big pattern that we see with benign. Slow to fill, slow to wash out. Malignancies, though, behave a little bit differently. We've got hepatocellular and non-hepatocellular. And a big thing with this, it's going to fill almost immediately. It's going to be very quick and hyper enhancement. And then we start to see some changes with how the blood vessels remain filled in that later arterial phase. And then again, we're going to watch the washout part of it. Does it stay enhanced? Does it kind of start to slightly wash out? Do we see a really strong washout or maybe no enhancement in the late phase? So there was a couple other words in there that I said, wash in and wash out. So wash in patterns really reflect the vascular supply, and it's going to tell us how quickly the microbubbles enter the lesion. Again, a rapid wash in, especially within the first 10 to 20 seconds, usually means that the lesion is hypervascular, like a hepatocellular carcinoma or metastases. In contrast to that, though, a slow or peripheral wash in often points more towards a benign lesion. Hemangiomas, for example, show nodular peripheral enhancement that slowly fills in. And washout, again, is just as important as wash in. This is going to refer to how quickly the lesion loses its contrast. So a lesion that lights up early and then fades before the surrounding liver parenchyma is often suspicious for cancer. The degree and the timing of the washout are key. So early and marked washout is more suggestive of a malignancy, where benign lesions tend to enhance longer and then wash out later, or sometimes not even at all. So I'm going to show you an example of a wash-in and a little bit of a washout of a metastases to the liver. It came from a primary renal cell carcinoma. So you'll see when the video starts on B mode ultrasound on the grayscale, we're going to observe multiple ill-defined lesions in the right lobe of the liver. And then these lesions you'll see are kind of hypoechoic to isoechoic, making them a little bit tricky to characterize on the grayscale alone. After they put in the sonoview contrast, the lesions are going to show up really, really early and really intense. So that's hyperenhancement, especially compared to the surrounding liver tissue, which will eventually get the contrast enhancement. But the fact that those lesions hyperenhance so quickly, that's going to be a red flag for malignancy. We'll then see a little bit of a transition into the portal venous phase, where we start to see washout of the metastases, and then the liver kind of remains in its brighter phase. And so again, that quick washout also supports that malignant etiology. So the combination of that early uptake and marked washout are kind of a classic pattern of malignancies. So let's go ahead and watch the video. So again, a lot of units, we're going to start with a grayscale and a dual screen with a contrast enhanced part. And then we're going to see those lesions light up really quickly. Notice we can hardly see those on the grayscale, but they light up super quick. Rest of the liver is just kind of dark still. Then we'll see that the rest of the liver starts to brighten up and those lesions start to wash out. There's the kidney, super bright, and then we see that the lesions have lost some of their enhancement at that point. Again, marking red flags for sure for malignancy. So we already did a little bit of a sneak peek to physics. Let's go back and revisit it just a little bit here. So when exposed to ultrasound, microbubbles behave in a way that tissue does not. It's going to oscillate. That is that they're going to expand and contract. And that expansion and contraction are going to create strong non-linear echoes. These echoes then are picked up by the ultrasound machine and separated from the tissue signals. So the manufacturers have gotten really good at kind of figuring out how to hone in on these really strong nonlinear echoes, allowing us to use a contrast-specific imaging mode. So remember, it's very important to set up your machine correctly when you are using contrast agents. The biggest thing to keep in mind is what is your mechanical index. Remember that your mechanical index is something that we can see and monitor on our machine. So here we've got that example. We can see the thermal index and the MI, the mechanical index. This is paying attention to kind of the strength of the beam from the mechanical pressure point of view. And so again, if we kind of think back to our physics, when the compression portion of the sound wave comes through, the bubble has a lot of pressure on it, and it's going to cause it to shrink down. When the rarefaction portion of the sound wave comes through, that allows the bubble to expand. Now, if we have a really high mechanical index, we'll start on this side. If we have a really high mechanical index during that rarefaction portion, that's going to have a very, very low pressure, allowing the bubble to indefinitely expand to the point where it'll just rupture. And that's not helpful. We won't get any harmonics out of it. We won't be able to see it flowing through the blood vessels. So that's not helpful. So oftentimes we're going to choose something in kind of that mid-range. We're going to get some harmonics out of it. As that compression comes through, it'll shrink a little bit. As the rarefaction comes through, it'll expand and then shrink and expand, doing that oscillation piece of it, but irregularly, which is what causes the harmonics, which is then picked up by the machine. If we use too low of a mechanical index, as we can see here, what we end up getting is just a very predictable shrink, expand. It's not nonlinear like these kind of mid mechanical indices would give us. So really low mechanical indices actually don't give us any harmonics or contrast imaging out of those bubbles, and also not effective for what we're trying to do. And then on the bottom here, we just have an example of a bubble going through different phases. As a sound wave goes through it, you can see it is very contracted, and then it can expand, expands a little bit more, contracts again. So as that sound wave comes through, it'll behave very differently as each part of that wave travels through it. So a lot of our more modern ultrasound machines are going to have a dedicated contrast mode, usually labeled somewhere in like a harmonic or a pulse inversion type functionality. These modes are going to be really good at suppressing the background tissue echoes and then help to amplify the signal from the microbubbles. And again, we usually use that split screen so we can see grayscale on one side and then that contrast enhanced mode on the other side. When we were talking about contrast agents earlier, we were talking about how they have that shell around them, and that shell needs to be sturdy enough to allow for the bubbles to make it into the bloodstream and then interact with the sound wave itself. But they are still pretty fragile. So when we are introducing microbubbles into the bloodstream, there's a couple things that we keep in mind. First off, we need to use a big enough IV. So usually 22 at the smallest, not uncommon to use a 20 or an 18. And then we want to make sure that we don't have any sort of filters in our line, because that'll just destroy the bubbles before they even get a chance to make it into the bloodstream. A lot of times we're going to use a 3-way stopcock. So that's what we're seeing here. The contrast itself is usually going to be connected to the part that would connect directly into the tube. So this is the contrast with this, and it's going to give the least path of resistance, and we're just going to be able to inject that contrast directly into the IV tubing. And then on the perpendicular side, we usually have that saline flush, So once we introduce the bubbles into the IV tube, we can continue to push them into the bloodstream using that saline. Now we saw earlier too that the microbubbles usually come in a little vial. That just needs to be shaken for about 10 seconds to activate it, and then once it's shaken, those bubbles usually will hang around for about 6 to 8 hours. So it really doesn't take a whole lot of contrast to get diagnostic images. In fact, a lot of patients really only need about 0.5 to 1.5 milliliters of contrast to get those really nice images. Back in the early days of contrast agents, a lot of times the agents were given in really large doses, but that often caused acoustic shadowing known as a bubble block, and then that would limit the visualization of the deeper structures. So today's agents and ultrasound machines are much more sensitive, which allows for smaller doses and then better image quality as well. We always kind of adjust the dose based on the patient's size and what organ we are trying to look at. We also talked earlier about how safety is such a major advantage of the contrast-enhanced ultrasound. Remember that the UCAs don't harm the kidneys, and they really have a very low risk of allergic reaction, way, way lower than the CT or MRI contrast. So there's really not a need then to screen for renal function, which is helpful, and then we know it's also going to be safe for most of our patients. Side effects, usually, again, very mild or self-limiting, might be kind of like a transient nausea, sometimes a headache, but usually those will resolve very quickly as well. So again, this makes contrast-enhanced ultrasound incredibly safe for most patients, especially those with comorbidities or any sort of allergies, and even our pediatric patients. So pediatric patient contrast imaging originally started very much off-label, but that's starting to change as Lumason is now FDA approved for pediatric liver imaging. So in children, it is so important that we minimize radiation. So it's fantastic now that we can do contrast-enhanced ultrasounds versus putting them through a CT or possibly even needing to sedate them for an MRI because MRI is so motion sensitive. It really offers a new way to look at pediatric lesions. In fact, this is a study, this was in a trauma patient. They were looking at the liver of a pediatric patient and they were kind of looking through this area here thinking, oh, that looks a little weird. So they pushed contrast through real quick. We can see that the liver lit up as it should, but then we have this kind of voided area, and this voided area actually represents a laceration on the liver. So because blood changes over time, at the moment that they were imaging, that blood had basically switched to an echogenicity that was very homogeneous with the liver tissue. As more and more pediatric studies are published, I imagine that we'll see a greater adoption of contrast-enhanced ultrasound in the pediatric population. One of the things that's kind of exciting is that they're starting to do some work on targeted microbubbles. And Sonozoid, which we had mentioned earlier as one of the 4 main types of contrast, it actually offers a liver-specific phase where the Kupffer cells of the liver are going to trap the Sonozoid a little bit more, which allows for delayed imaging of hepatocellular lesions. We're also seeing that newer agents are being designed to bind to specific tumor markers, so that can help identify if those contrast agents show up in a nodule. That might help us to diagnose it a little bit more effectively. There's also a lot of work going on right now too, is using microbubbles with medicine on them as a way to deliver medicine directly to a tumor. The sonography involves, I would not be surprised if we saw a lot more of this real-time kind of diagnostic and therapeutic tools being put in our daily practice. All right, so to finish up this lecture, let's go ahead and just take a look at some different examples of using contrast in the liver, kidney, and thyroid. So these first ones of the liver are actually from a book called Liver Ultrasound from Basics to Advanced Applications by Adrian Lim and Matteo Rosselli. It's actually a really, really good book. There's tons of great information in there if you want to learn more about liver ultrasound and using contrast. And then there's actually tons of videos that go along with it as well. But I wanted to share some of their pictures with you. I hope you check out their book to see more of them. So here we see a focal lesion in the right lobe of the liver. On B-mode ultrasound, it's large, it's hypoechoic, kind of heterogeneous. So these are all features that raise suspicion, but aren't necessarily definitive for malignancy. As we move into the contrast-enhanced ultrasound imaging, the lesion starts to demonstrate arterial phase hyperenhancement, which again is a classic feature of hepatocellular carcinoma and most malignancies. So this is at 17 seconds, this one is at 19 seconds. And here we are at 25 seconds, all very hyper enhanced. Now here we are at the minute and 21 second mark, and this is going to be more into the portal venous phase. The lesion itself has now become a little bit more isoechoic compared to that surrounding liver tissue, which makes it a little bit more difficult to distinguish. And then at 4 minutes into the late vascular phase, we begin to see kind of a subtle hypoenhancement, which kind of would indicate a little bit more of a mild washout. This is a pretty common pattern for hepatocellular carcinoma. All right, so the hepatocellular carcinoma had a pretty complex vascularity component to it, right? And that makes sense then why our contrast-enhanced ultrasound also shows that complexity, because again, we're looking at the vascular perfusion of this lesion. Now let's look at something that doesn't have anything internally, like a hepatic cyst. Now we most likely would be able to recognize this on grayscale as a hepatic cyst. We would see the smooth walls, anechoic through transmission, right? And so that's probably what this would very much look like up here. A very simple hepatic cyst would also appear like a simple hepatic cyst with no enhancement. But what if you saw something like this one on the bottom here? This looks much more complex. This one might be a little bit more concerning for some sort of malignancy or large benign tumor. But we go ahead and do the contrast ultrasound, and because it is a cyst, we see no enhancement. There's no vascularity in here. So most likely this was just a hemorrhagic cyst at the time. Let's talk about one more kind of complex structure, and this is an FNH, or a focal nodular hyperplasia. If you think back to what you know about focal nodular hyperplasia, we know that this basically has all the same components as the liver. It has the Kupffer cells, the hepatocytes, all the biliary, the portal veins, all those components are there. They're just kind of in a disorganized way. So we end up referring to focal nodular hyperplasia as a stealth lesion because it's really, really hard to see on grayscale in the liver because it's made of all the same content, right? So in this case, we're going to start with our pre-contrast phase. So this is what we're seeing here. We don't see a lesion. Like we probably on grayscale was like, maybe something's there. I can't really tell. Well, that's where contrast comes in really helpful. So we're in the area that we think we want to be in. We can't really see anything, but again, this is pre-contrast. Contrast gets put in, and we go through the arterial phases in our images of B, C, and D. But again, we're seeing a pattern of how the contrast is flowing into the lesion through the blood vessels. And what we see right away with focal nodular hyperplasia is this kind of spoke wheel pattern coming in from the periphery as it travels to the center. So we can see that starting here, it gets a little bit more filled in C, and then it almost gets completely filled in by D. But what we also see then is this central scar. And so we can see that really, really nicely. Sometimes we can see it with grayscale, but it's beautifully demonstrated here with the contrast. So the lesion does kind of quickly become enhanced, but then what we see is that that enhancement stays. So between that spoke wheel pattern, the central scar, and then the kind of persistent enhancement through the venous phase and the late phase, we're starting to again see a very classic pattern of focal nodular hyperplasia. All right, let's take a look at a case of squamous cell carcinoma in the kidney. This is a 50-year-old man with a 7-centimeter mass on the upper pole of the left kidney. It was again later determined to be a squamous cell carcinoma, super rare cancer of the kidney, less than 1%. So looking at A here, we are seeing on grayscale ultrasound, the lesion appears kind of isoechoic, aren't real strong borders, but we can tell there's something kind of chunky and hunky going on up here. But nothing really, really obvious that's like, oh, that's definitely a cancer, but we're definitely concerned about it. So then in B here, we put color flow Doppler on. This is actually showing a lack of kind of intramural vascularity, which can actually be kind of misleading. A lot of times when we think of cancers, we think of increased blood flow in the lesion area. So now that we don't have that increased blood flow, we might kind of be thinking, well, maybe it's not as scary as it kind of looked in grayscale. It doesn't have that increased flow. So this might just really be a matter of slow flow within the lesion or disorganized flow that we're just not detecting with Doppler. So it makes sense then. Let's go ahead and take a look at it with a contrast agent. Now the article that these pictures came from was a study on using SonoView and Sonozoid contrast agents with renal masses. So this first one here is using SonoView. And when we put the contrast in, it actually shows a non-enhancing central area that you can see here. And then we see that it's kind of surrounded by a pseudocapsule. Now this is going to raise concern that there is necrosis with some sort of preserved peripheral vascularity in this lesion. But with the Sinusoid contrast agent over on this side, what we end up seeing is a very heterogeneous hypoenhancement, and this is going to be more classic of a malignancy. So that pseudocapsule we can actually still see pretty well, but now we are seeing much more of that poorly vascularized area, which is more consistent with tumor necrosis, but also then raises our concern a little bit more for malignancy. So again, just kind of shows you the importance of using appropriate settings in grayscale and in color, and then choosing the appropriate contrast agent for your contrast ultrasound. And then this last one is just to kind of show you a study that was using a contrast agent for a thyroid ultrasound. Now this actually ended up being a benign adenoma. It doesn't look super benign on ultrasound here, but we've got, pretty well marcated borders here, but we do have some microcalcifications, some edge shadowing coming off of it here. So then they did elastography on it. Just as a reminder on elastography, usually the stiffer the tissue reads, the more concerning for malignancy that it is. And so we're seeing kind of this red area overlapping with what we're seeing on grayscale, again, raising concern for malignancy. So then they went ahead and did a contrast ultrasound on this, and we get kind of the same thing. We're seeing kind of a lot of vascularity into the center of this lesion. And so if we go by what we talked about with the kidneys and the liver, then again, this is a little bit more concerning for a malignancy. But after biopsy, they ended up finding out it was a benign adenoma. So despite everything that we are seeing, again, ultrasound isn't perfect. It's just a reminder that more studies need to be done, and there definitely are being conducted all over the world. So remember that contrast isn't just a radiologist tool. It really is a real-time ultrasound-based way to solve complex cases right at the bedside. And as more departments adopt contrast-enhanced ultrasound, sonographers trained in these techniques will be better prepared for the future and better equipped to advocate for our patients.